The first test that I'm going to be demonstrating is the cotton test to assess for a high ankle sprain. So I'm going to stabilize the distal tib fib and place my other hand on the talus and glide it laterally. A positive test here would be a reproduction of the patient's complaints, a clunk, or an increase in laxity. A medial glide can also be done where I'm going to medially push over the calcaneus and talus, applying a medial force as done here, and I'm trying to gap the talus into the mortise, and again, a reproduction of the patient's complaints or a clunk is a positive test result. This next test is called the medial subtalar glide test, so I'm going to stabilize at the distal tib fib and apply a medial translation force and glide at the calcaneus, and a positive test would be a clunk or excessive motion noted compared to the uninvolved side, indicating a high ankle sprain. This next test is called the Kleiger external rotation test to assess for high ankle sprains. So I'm going to grab the calcaneus and externally rotate the foot while stabilizing the tibia. This motion is going to open up the mortise, and a positive test would be pain at the distal tib fib ligaments or at the syndesmosis. This test is called the fibular translation test, which is another test to assess for a high ankle sprain. So I'm going to come proximal to the lateral malleolus and use the heel of my hand to provide a posterior translation on the fibula. So I can also do a anterior translation with my fingers, finding the fibula and then providing an anterior force. So a positive test would be a reproduction of the patient's pain or a greater displacement of the involved fibula compared to the uninvolved. The squeeze test is another test which can be done to assess for a high ankle sprain. So I'm going to place my hands above the malleoli on the distal third of the tibia and fibula. I'm going to compress here at this area, and a positive test would be reproducing the patient's complaints of ankle pain due to mortise or syndesmosis involvement. Next is the heel thump test, which is another specific test to assess for a high ankle sprain. So what I'm going to do is I'm going to strike the calcaneus with my fist, and if this reproduces the patient's pain in the syndesmosis region, that would be a positive test. The anterior drawer test is done to assess for a lateral ankle sprain, specifically at the anterior talofibular ligament, or to assess for stability at the ankle after recurrent chronic ankle sprains. So I'm going to stabilize the distal tibia and grab the calcaneus and pull forward with the foot in neutral. So a positive test would be excessive translation or a clunk, and I'm going to make sure that I compare this to the uninvolved side. Another test to assess for a lateral ankle sprain is the talar tilt test, so I'm going to come right over the talus and off of the inferior edge of the lateral malleolus, and then I'm going to create inversion at the talus. A positive test would be excessive motion compared to the uninvolved side, a clunk, or reproducing the patient's complaints of lateral ankle pain. This would indicate involvement at both the CFL and ATFL. The Homan sign test can be done if you suspect a DVT or other vascular issue. So I'm going to squeeze at the patient's calf and note for a reproduction of his pain. Since this is not a specific test, I can increase the sensitivity by bringing his foot into passive dorsiflexion and then squeezing the calf to see if I reproduce his deep calf pain or tenderness. That would indicate a positive test response. This test should also be done in conjunction with palpating for a dorsal pedis pulse. The Berger's test is used to assess for vascular insufficiency, including peripheral vascular disease. I'm going to elevate the patient's leg to about 45 degrees and hold this for 3 minutes. In the meantime, I would assess the foot for any blanching or collapsing of veins. After the 3 minutes, if I see those signs, I can put the patient's leg down into the dependent position, and then I'm going to assess the dorsum of the foot and see if there is a return of color, and if there's no full return of color within 30 seconds, that would indicate a positive test. The Thompson test is done if you suspect the person has an Achilles tendon rupture. So I'm going to squeeze at the muscle belly of the gastroc and soleus, and here the patient has an intact Achilles, demonstrating a negative test result since his foot is going into plantar flexion as I squeeze there. A positive result would look like this, getting no movement upon squeezing the muscle belly, which is typically noted with a complete tear. The Matlis test is another test done for a suspected Achilles tendon rupture. So with the patient in prone, I'll have the patient flex his knee to 90 degrees, and I'm going to observe what happens at his foot and ankle. Here there's no drop or lag, that's a negative test, but then again, I'll have the patient flex his knee to 90 degrees, and if the Achilles is compromised, a drop or lag would be noted right there upon knee flexion, indicating a positive test. This next test is called the Royal London Hospital test, done if you suspect Achilles tendinopathy. So I'm going to squeeze at the Achilles tendon and know if the patient complains of tenderness or pain. So then I'm going to have the patient actively dorsiflex and squeeze again at that tendon. A positive test response would be a reduction in the patient's complaints with the maximal dorsiflexion. The Tinel sign is a neurological test where I'm first going to percuss over the anterior branch of the deep fibular nerve right above the malleoli, and a positive test here would be a reproduction of the neural numbness and tingling when percussing over the nerve. So then I'm going to percuss medially over the tarsal tunnel, assessing the posteriotibial nerve. Again, a positive test result would be a reproduction of that numbness, tingling, or a zing-like sensation when percussing over the nerve. Morton's test is done to assess for a Morton's neuroma in the intermetatarsal plantar digital nerve. So I'm going to compress the medial and lateral part of the foot, and a positive test would be reproducing the patient's complaints of numbness, tingling, or pain. With the Feastline assessment, I'm noting the alignment from the medial malleolus to the plantar aspect of the first MTP, as well as the position of the navicular tuberosity and weight bearing. Here the patient has a negative test result as his navicular falls right at the Feastline. A positive result would be either the Feastline running below the navicular tuberosity indicating a pes planus foot, or the line above the tuberosity indicating pes cavis. The functional hallux limitus test is done to test the first ray and hallux MTP mobility. So first I'm going to find the patient's subtalar joint neutral, and after I find this, I will then passively perform great toe extension. A positive test result would be plantar flexion noted at the first MT with the passive MTP extension. This indicates abnormal mid-tarsal joint function and pronation. The windlass test is done to assess for potential dysfunction in the plantar fascia. So with the patient in weight bearing, I passively extend the MTP. A positive test would be a reproduction of the patient's plantar fascia pain,